All right, this lecture is going to be on pacemakers. It comes from Chapter 11 in Mastering the 12-Lead EKG. The first thing we're going to talk about are indications for pacemakers. And these are electronic devices that are used to do a few different things. And so one of those is to treat symptomatic patients, patients who are unstable or having significant symptoms due to either a heart block or bradycardia. So in the last lecture, we talked about the AV heart blocks, and you can see when the ventricular rate gets very slow because of either several dropped QRS complexes or because of a bradycardia like a ventricular escape rhythm, then one of the things we can consider treating that patient with is a pacemaker. So if medications and things are not working, a pacemaker may be something that we rely on, especially if that condition is going to be permanent and cannot be reversed. Another treatment is overdrive suppression of a tachycardia. I believe we talked about this in conjunction with Torsades de points, and so you can overdrive suppress a tachycardia by using a pacemaker. Another thing you can do is improve synchronization of the ventricles. And although we haven't talked about it yet, there's something called a left bundle branch block where the left bundle does not depolarize, and so this causes the ventricles to contract out of sync. And in patients with congestive heart failure, cardiomyopathy, poor ejection fractions, improving synchronization of the ventricles is very important, and pacemakers can be used to do that. There are a couple different groups of pacemakers. There's those that are temporary and those that are permanent. Temporary pacemakers are either used to buy time until we can get a permanent pacemaker placed, or for things that we know that are reversible and will not be long lasting. So we'll talk about each of these in order. So temporary pacemakers include transcutaneous, transvenous, and epicardial. And permanent pacemakers can be those that are placed into the chest that either pace the atria, pace the ventricles, pace both the atria and ventricles, or can be what's called a biventricular, and this is where we synchronize the contraction of the ventricles. And oftentimes those are accompanied by a device called an ICD, or internal cardiac defibrillator, something that can actually shock the patient's heart if they were to go into a tachyarrhythmia such as ventricular tachycardia or VFib. Here's a picture of a gentleman with some pacing pads on. In fact, these are the same pads we would use to defibrillate or cardiovert a patient if needed. The patch that you see is on the right upper chest and on his left side, and it's connected to this machine sitting in the chair. And so you can see on that screen there's a EKG reading that goes across. And so if we were to need to pace this patient, we could use a machine very similar to this. And basically we would just set the rate and set the amount of energy that we need in order to capture that myocardium, and we could pace the patient. This is usually an uncomfortable thing for the patient to endure. You're having to send electricity through the chest, and if the rate's set at 60 beats per minute, that means they're getting shocked once every second for however long you need to pace the patient. Now, there's a video down here below on YouTube that you can watch of a gentleman that's actually being paced, and I think he might have just been put up to it. He's not even really in need of it, but it's kind of interesting. You can see how the chest moves with each of these each time he gets paced. Transvenous pacemaker, they're very useful for patients who we know may need to be paced for a prolonged period of time. It's much more comfortable than a transcutaneous pacemaker. However, it does require some expertise to put this in. As you can see, there's several parts to it. One is the sheath introducer. This is usually placed into the femoral vein along with the transvenous pacing catheter that's fed up through that sheath into the femoral vein and up into the right ventricle. Once that's where it's supposed to be in the heart, then they connect this to the pacing generator where they can set the rate and the amount of energy that needs to be in the device in order to capture the myocardium and pace the myocardium. Down below is another YouTube video you can watch if you're interested, and this is how they place the transvenous pacemaker. Epicardial pacing is also another type of temporary pacemaker. As you can see, these wires are placed into both the into the atria and the ventricle, and those come out through the skin surface and out to the chest. These are placed during cardiac surgery. So after the patient's had open heart surgery of some sort, they may place these epicardial pacing wires and leave them dangling out of the chest just in case the patient was to experience some conduction problems after surgery. And so that can be connected to an external generator, just like the one you saw with the transvenous pacing. Permanent pacemaker, on the other hand, is a device that's going to actually be placed under the skin in the chest, and usually in the left upper chest. It has a computer and a generator in it, and that's this little silver thing you see in the middle. It will have a battery in it. It's a very smart thing. It knows when to turn itself on, when to turn itself off, and that wire would be fed down into the right ventricle. Sometimes there may be a second wire that's going into the atria, or even a third wire where you have a biventricular pacemaker and an atrial pacer. These are fairly small. However, if you had a patient with an ICD, those tend to be quite a bit bigger. Here's a chest x-ray of a patient with a permanent pacemaker, and if you look carefully, you can see that wire coming down and into the right ventricle here. And you can also see that this patient has some sternal wires. That tells me this patient's had open heart surgery in the past and possibly maybe a CABG. Here's the external view of a patient with a permanent pacemaker. You can see that this guy's got a bulge in his chest. That's a permanent pacemaker. You can see the scar just above it where they made the incision to place the permanent pacemaker. And if you look carefully, you can see this patient's also had bypass surgery. You can tell a lot just from looking at a patient, right? So we gained a lot of information about this guy just simply by inspecting. So let's talk about the EKG of pacemakers. Characteristics of a pace rhythm, you're going to typically see what's called a pacing spike. And this is a vertical deflection that's going to happen either just before the P wave, just before the QRS complex, or both, depending on what's being paced. Now, oftentimes they're big enough that you can see, but sometimes they can be very small, just small amplitude, and you might miss them. So if you didn't know the patient had a permanent pacemaker and you saw this big wide QRS complex, which is another characteristic, you might think they have something else going on, whether it be a ventricular rhythm or even a bundle branch block. So make sure you're aware of the patient either having a pacemaker or look for those pacing spikes, which are often pretty easy to spot. Wide QRS complex is a common finding in a patient with a ventricular pacemaker. This is because they usually only have one wire going down into the right ventricle. So it resembles a left bundle branch block. It resembles a block of the left bundle where there's no electricity going down on the left side of the heart. And that's because the electricity is just coming from that pacing wire on the right side. Because the ventricle, only one ventricle is being paced, and the depolarization has to travel all the way from the right to the left, and it's not going through the normal conduction system, we end up with a wide QRS complex. And just like what we talked about premature ventricular contractions with wide QRS complex, that they have ST wave discordance just like a paced rhythm does. So because we have abnormal depolarization of the ventricles, we also have this abnormal repolarization. If you don't remember ST wave discordance, this is simply where when we have a negative QRS complex, we expect the ST wave to be discordant or opposite of that. So if it's a negative QRS complex, we have ST elevation and an upright T wave. If we have a positive QRS complex, then we'll have ST depression and an inverted T wave. Here's some examples of paced rhythms. The one at the very top is an atrioventricular pacemaker, or an AV pacemaker. And the reason we know that is simply by looking at the pacing spikes. We can see there's a pacing spike just before the P wave and a pacing spike just before the QRS complex. So in this rhythm, both the atria and the ventricles are separately being paced. Now we know there's only one pacing wire here, and we can see that it's causing this wide QRS complex, and along with that we have a little bit of ST wave discordance. So that ST segment is slightly elevated, and we have an upright T wave. The second EKG here we can see is simply atrial paced. That pacing spike comes just before the P wave, and there's no pacing spike before the QRS complex. The QRS complex here is narrow because once depolarization has been started by the pacemaker in the atria, it's able to continue on very normally down through the AV node and through his Purkinje system. So we have a narrow QRS complex. The final EKG, if you look, you can see a P wave, and this is inherent to the patient because there's no pacing spike before it. And then we have a pacing spike with the wide QRS complex. Again, that QRS complex is wide because the wire is typically placed into the right ventricle. Depolarization is having to go all the way from the right to the left, and it's not through the normal conduction system. Let's talk about a couple of problems you can get with the pacemaker. One is a failure to capture. And so this is where the pacemaker is firing like it's supposed to, but it is not capturing the myocardium. So this is indicated by pacing spikes that are correctly timed. There's a pacing spike where there should be, but it does not cause depolarization of the myocardium. So we're missing either the P wave or the QRS complex. The problems that can cause this would be either the lead has become dislodged from the myocardium or there's some electricity leaking out around the circuit, so we're not getting the full impulse. The problem may be with the generator, and that's that silver thing we saw, the permanent pacemaker generator, or the box that lies outside the patient in the case of a temporary pacemaker. So maybe there's not enough energy, there's not enough output from that pacemaker. Now, the myocardium can also be damaged or have some problems because of electrolytes where it's requiring more energy than it did before to depolarize. So these settings on the pacemakers may have to be adjusted in order to give enough energy to capture the myocardium. Here's an EKG of a patient who has failure to capture. So you can look at these first two beats. You see that the patient has a ventricular paced rhythm. He has a pacing spike before each of these QRS complexes. You see that it's nice and regular and that the next pacing spike is occurring when it's supposed to, so it's a properly timed pacing spike, but it's not causing a depolarization of the ventricles as we would expect. And so this is failure to capture the myocardium. You can see there's a failure to capture here, 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 and here. Another type of pacemaker malfunction is a failure to sense. So this is where the pacemaker is set to notice when the patient has an inherent beat and turn itself off. But there are times when the pacemaker is not sensing things properly. And so what you get are these extra, inappropriately timed pacing spikes that may end up landing right on top of things like P waves and QRS complexes where they don't belong. So this is where the computer is failing to sense an intrinsic rhythm, either because that intrinsic rhythm has an amplitude that is really low in signal, or maybe there's poor lead contact. And so those are the problems that we would end up needing to look at correcting. So a failure to sense. And so let's take a look at this. You can see the patient has their own inherent rhythm here. It's actually pacing at a pretty good clip. And what we see are pacing spikes here right in the middle where we don't need them. This one seems to be appropriately timed as it lands right before the P wave, but this one over here comes immediately after a QRS complex. We don't need that to be paced right there. The reason that that's happening is it's a failure of the pacemaker to sense the inherent rate of the patient. The last pacemaker malfunction is one that's just failure to pace. So we have a slow intrinsic rhythm that we would expect the pacemaker to be kicking in. It should be turning on, we need you. Yet there are no pacing spikes and there's no pacing occurring. So this means that maybe the pacemaker is picking up activity that mimics an intrinsic rhythm. Maybe there is some outside electrical interference, maybe the skeletal muscle or diaphragmatic contraction, so maybe the patient's having tremors that can mimic electrical activity to the pacemaker and it turns itself off. External equipment such as MRI or electrocautery may also be confusing the pacemaker, and so we don't get pacing where we need it. Here's a couple of examples of a failure to pace. The first EKG, the patient has an inherent P wave followed by a pacing spike that has the QRS complex after. So this patient has a ventricular pacemaker. We can see that his P wave, his atria depolarized on its own, but we're missing a pacing spike here, and that means it failed to pace when we needed it to. So this is a failure to pace. Another example is this patient down here who had a P wave followed by a pacing spike followed by a QRS complex. There's a long pause here. We would have expected that pacemaker to kick in, and it didn't. So that is a failure to pace. That's it on pacemakers.